So today's topic we're going to talk about is ABA. I know some people might not be as familiar with it, so we're going to kind of get everybody up to the same page in terms of what it is, and then talk a little bit about some of the things that you can do to promote some of the behavioral strategies, and then some of the common misconceptions about ABA. So go ahead, Lindsay. ABA is a behavioral treatment. Why do we recommend them for children with autism? They're based on theories and principles of behaviorism. So think back to graduate school and classical conditioning, Pavlov's dogs, human behavior, both good and bad, adaptive and maladaptive. We don't really like to call it bad, is learned. So that doesn't mean that somebody sets out to teach a child to do something that's maladaptive, but the good news is that they can learn a new, more appropriate way to get that same need met or achieve that same purpose. So behavioral treatments are all based on that classical conditioning, which was then studied by B.F. Skinner in more of an operant way. So most of the field of ABA is based on operant conditioning, social learning, and the foundational work of Dr. Skinner. Go ahead, Lindsay. So what our field does is take a lot of that theoretical understanding of behavior and then apply it. So behavioral treatments are effective not only for reduction of challenging behavior, but also for skill development, specifically in children with autism. The earlier the intervention is started, the better the outcome. That's based on thousands of studies with different ABA techniques. There is also no medication that has shown to be effective or that is labeled specifically for treating those core symptoms of autism. So that's why we look at behavioral treatments. Go ahead, Lindsay. The definition of ABA, or applied behavior analysis, is the systematic application of these behavioral principles to socially important behaviors. We're going to talk about what that means a little bit later, but we're not looking at behaviors that aren't very impactful for the child's life, their functioning, their independence level, their socialization skills. And those decisions on what behaviors you're going to target in ABA therapy should be a group decision with the individual, most importantly, their family, and then the provider as well. ABA is an umbrella term. It's not one single technique, and all of the behavioral principles or techniques that are under that umbrella are grounded in operant conditioning. It is the most studied treatment for autism in terms of the number of research papers that are out there. And it takes a lot of those experimental methods beyond the lab to the applied setting. ABA is systematic in that we're looking at behavioral change through some kind of prompt fading or systematic way to teach something by taking the steps of something and breaking it down and slowly increasing the number of steps that they can do of a particular skill. ABA is also very data driven. We make all of our decisions based on what the data is telling us. It's a dynamic process, which means that ongoing review of data is driving which direction that we're going. Do we need to slow down a little bit? Do we need to up the level of reinforcement? Should we change how we're prompting? It's something that should be adapted in an ongoing dynamic way. And probably one of the most important parts about ABA is that it's individualized. There is no one size fits all. It should be developed, a program should be developed for a child based on their specific needs, interests, how they learn, and what motivates them, and what types of techniques work the most effectively for that particular child, and what level of comfort that the family has with those different techniques, as well as cultural and social concerns. Any of those should be addressed and interwoven into the programs that are developed. ABA principles that are often used include reinforcement, prompting, shaping, extinction, and lots of antecedent control. So those are just some of the behavioral principles that we're talking about in that definition. Next slide, Lindsay. The model that underpins our understanding of behaviors is called the ABC model. The B stands for behavior. And we look at what happens right before the behavior, which is the A, and that stands for antecedent. And the C is the consequence, or what comes after the behavior. And that's not necessarily an imposed consequence, like you're going to time out. It might just be what happens after that behavior. Do they get attention? Do they get a tangible item that they wanted? Do they get out of doing something? Understanding what happens before and after a behavior allows us to understand the function, or the why of the behavior. And once we understand the function of the behavior, then we can create a plan for behavior change to replace that challenging behavior with a more appropriate way of meeting that same need, or getting that same function met. So the typical functions of behavior include attention, either adult attention or peer attention, and that attention could be positive or negative. It could be tangible, so getting a whole bunch of cars, or getting different food items, whatever tangible thing that they like to collect. That could be a function of behavior. Another one is to escape or avoid something that they don't particularly enjoy. We see this a lot in the school setting, but also at home if there's certain adaptive things that they don't like to do. And then the last function is an automatic function, or like a sensory function, because it feels good. So once we understand the function, then we can replace that challenging behavior with a more appropriate one. Go ahead, Lindsay. The types of therapies that fall under that ABA umbrella include not only those that address those challenging behaviors, like doing that functional behavior assessment, but also skill-based therapies. And those include one of the earliest ones that was developed, discrete trial training, which was some of the low-VOS studies that were probably the earliest done in our field, but also newer therapies, newer teaching strategies, including incidental teaching or natural environment teaching. Pivotal response training is also more of a naturalistic approach. This also would include the early start Denver model that we've had another echo session on, verbal behavior, and early intensive behavioral intervention. Feeding services would also fall under this umbrella. There are lots of BCBAs who are part of that multidisciplinary feeding team. And I'm hopeful for the case presentation that we talked about, that maybe the ABA provider can work with the feeding team for this little guy and help implement some behavioral strategies to work with them. There's also another arm of ABA that deals with organizational behavior management, just so you guys know that that's out there. Next slide, Lindsay. I know I'm short on time. I'm not going to go through all of these different types of techniques, but just so you understand each one of them, I've listed under each one of them kind of what it entails. And a good ABA therapist is going to be able to evaluate, based on the assessment data, the different skills that are most important for the individual and the family, and figure out which one of these different techniques is going to be most appropriate to target that particular skill. One of the criticisms of ABA that people have is that it's like all discrete trial training at the table for 40 hours a week. And that's not what modern ABA looks like at all now. There are some skills that are very appropriate for discrete trial training. There's also certain learners that do well with this particular style, and there are certain learners who don't do well with it at all. So a really good ABA therapist is going to be able to take all of these and apply them appropriately for the skill being targeted, the individual, and what works best for them. Go ahead, Lindsay. So who can provide ABA? Anyone can implement behavioral strategies. That's why we train parents and caregivers and teachers and paraprofessionals with these different strategies and techniques. But ABA programs should really be designed and supervised by a qualified professional. We don't want to do any harm, right? So we want somebody who's going to do a really good job taking those skills, monitoring that data, knowing how and when to make changes. And those examples of someone who would be qualified would include a licensed psychologist with training in ABA or a board certified behavior analyst with experience in ABA treatment for autism. Next slide, Lindsay. So what does it look like? ABA should always start with an assessment and developing that behavior change program. So looking at previous assessments and then specifically individual skills assessments, developing goals based on those results with, again, the caregiver and the individual having input on what they want to target, what is most important for them, and what's their priority. Then implementation of that program, so delivering those interventions and collecting ongoing data. Every ABA program should involve a component of training so that parents, teachers, other therapists, anybody who's interacting with the individual are being consistent in terms of how they're presenting reinforcement, how they're prompting the child, so that they don't get confused and we stop making progress. So that training piece is a pretty critical one. And then another component of it is that progress monitoring. So reviewing that data that's been taken, adjusting the program as needed, and understanding if that individual and the family is satisfied with that behavior change program. Both how that's being implemented, are they comfortable with the procedures, and the results? How are they feeling about how much progress is being made? And supervision is the last piece. It really should be by a psychologist or a behavior analyst. Go ahead, Lindsay. ABA can be delivered anywhere, in a park, in a home-based environment, in a clinic-based environment, in school, at the swimming pool, wherever the child happens to be. ABA can take place pretty much anywhere. It's really nice if you can implement it across settings to help with generalization of those skills from one environment, one person to another, but it pretty much can take place anywhere. And it really should take place where the challenging behaviors are happening. Programs can also vary in intensity and duration. A lot of the early studies, the Lovaas study, that was one of the earliest ones, was a high intensity program. And that one was like 40 hours per week. It can vary based on the payer, the funding for how much hours are approved. It can vary based on the availability of the family and the therapist. But one of the things that's really important to talk about with the ABA provider is what dose is really going to be necessary to have effective behavioral change. So that's a really good thing to recommend your families talk to their providers about. Like, okay, you only have this much time available. Where am I going to get the biggest bang for my buck? And is that enough time to really get behavioral change? Next slide, Lindsay. How can you as a provider support behavioral strategies? The first one is to communicate with the ABA provider, sharing reports. And one of the biggest things that we as ABA providers recommend to families is to help rule out any physiological reasons for the behavior that we're talking about. We're taught in graduate school that you should always rule out physiological reasons prior to trying any behavioral strategies. And these are just a list of the things in my experience with families that I've worked with that have been physiological reasons for some of the behaviors that we have seen. So um, this is not a rule out list. This is just a list of things that have happened to come up while I've been working with different families. Next slide, Lindsay. Some other ways that you can support behavioral strategies are to use some of them in your office. Having a visual schedule for office visits to increase predictability can be a really great tool to make those visits go a lot smoother. This is an example down in the bottom right of what a visual schedule might look like for a doctor's exam. And that can really help them as you check off the little boxes on the bottom and do that same routine in the same order for those patients to help give them some predictability and comfort in what's going to happen. The fear of the unknown is often a source of challenging behavior, especially for kiddos like the one in our case study today. So this can be a great strategy. A visual timer might also be helpful for some, knowing that this appointment is going to end, although you might not have a great guess for when it's going to end. Sometimes visual timers can be an effective strategy for some, and it might be helpful just to have one in your office. It's nice to have reinforcers like the stickers and lollipops, but even to bring some into completing different parts of the exam. My child's very stressed out by the blood pressure cuff, so rewarding her for getting her blood pressure taken with a reinforcer earlier in the appointment has been an effective thing for our family for doctor visits. So be thinking about ways to positively reinforce any kind of behaviors that you want to see happen over and over. A big one for me is to talk to the individual, not about them, because any kind of talking about their challenging behaviors, talking about things that are a struggle for mom and dad is negative attention. And so it bothers me when people talk about my child in front of her. So I like it when providers will actually talk to her as much as possible, but we want to try to decrease that amount of negative attention they might be getting for the challenging behaviors. Processing time is a really important piece for a lot of our kiddos on the autism spectrum. So making sure that you give them some time to process their request. Like, can I look in your ear? Wait a little bit to see if they're going to respond. And let them be involved as much as you can in the exam, touching the instrument or the item that you're using, warning them of what's coming next. All of these things can help. And then a basket of sensory items might not be a bad idea that they might enjoy, that might help distract them from difficult parts of the exam, of the testing, whatever it happens to be. These are just some ideas of things that have worked well for us, but just an idea of another thing that might help. Lindsay, next slide. Finding an ABA provider can be a challenge, and especially in Idaho, where we don't have very many BCBAs. So as you're helping families navigate finding a provider, some of the things that you might help them consider is the amount of training that this person has that's going to be implementing behavioral strategies with them. What degree level do they have? What's their basic knowledge in these different principles? Have they done a supervised experience or a practicum? Kind of what is their background in the field of ABA? And then here's a list of things what to ask as they're starting ABA therapy. So this mom in the case study could ask like, okay, what services are they going to provide and to whom? Like just with the child? Are they going to provide training? What's that going to look like? And also ask about insurance coverage. And within the state of Idaho, if you can't find a BCBA, you can also receive behavior intervention services from the Developmental Disabilities Program through the Idaho Department of Health and Welfare. The providers that are in that program will have a variety of background knowledge, a variety of different degree levels. So it's important to ask so that mom is comfortable with who's providing and what's going to happen. They should address concerns both in therapy or treatment about the behavior change, if they don't like what's going on, or they don't like what they're prepared to do. If they, for example, they're targeting eye contact, but they don't want the provider to target eye contact, help them talk to the provider, work through that. So this is just a list of questions on what they can ask, and I would encourage them to. Lindsay, next slide. If you want to find a BCBA, the best way to do it is to go to our governing organization, which is the Behavior Analyst Certification Board. This is our website. If you click on Find a Certificate, then you can pull up this search engine. It allows you to search by state, postal code, find somebody who's within 5, 10, 100 miles of you. So that's the best way to find a BCBA. And you can actually message them through this particular website after you've got them pulled up through that search. So there's a lot of misconceptions out there. We talked a little bit about eye contact. Anytime that you're choosing target behaviors, you should absolutely have involvement of the individual if possible, their family and caregivers, as well as the therapist who's going to be providing the therapy. So that should be a group decision. And the methodology for each target behavior should be a really well thought out by the ABA provider. Some people out there think that ABA is only discrete trial, and that doing discrete trial for 40 hours a week can cause trauma to children. And that's really not what goes on with modern ABA. A lot of providers look at naturalistic interventions, and you really should match the intervention to the learner and the skill level. But it's not absolutely critical that you do discrete trial. I have one learner who that's just not going to work forever. And so, at least not in this point in her life. It could potentially be something that would work really well for her later on as she gets older. But right now, that's not an effective methodology. So I don't use it. Many out there think ABA is only consequence-based. They're like, oh, that's only sticker charts and bribery. And really, ABA is a lot more than that, because we evaluate antecedent strategies in terms of what happens before the behavior. How are we presenting a demand? How are we controlling the environment? There's a whole list of prevention strategies, antecedent strategies that are implemented in addition to consequence strategies, because those are the two things that we can change in the environment. We've talked a little bit about trauma. And one thing I want to end on is that in the field, any BCBA is held to an ethical compliance code. This is not just a set of recommendations in terms of our ethics and principles, but it's actually a compliance code. If I violate our ethical compliance code, I could lose my certificate. So it's something that we take very seriously because of the criticisms in our field. And it's very well laid out in there what procedures, what you have to do as a BCBA to make sure the client's included, to make sure you're doing everything ethically. It's multiple pages long. And it covers things like consent or assent. What procedures are you going to do? Did you review them with the client ahead of time? Everything needs to be signed off on. And as a BCBA, I like to make it a priority that the children I work with want to spend time with me. I want to be reinforcing to them. I want to be their favorite person. Even though we're working on skills and sometimes hard things, that is critical to me. And so if I see a child not happy when I walk through the door, if I see them in any way showing signs of being uncomfortable, then I go back to building rapport, building them up with positive reinforcement. And also it's important to be flexible and have a backup plan and 2 other backup plans for that. Next slide, Lindsay. We also have a link on our website to a resource guide that I put together in terms of how to coach families to find a provider, what questions they can ask, how to evaluate the process, all of that's in there. So that link is available. I saw a question in the chat about what discrete trial is. A discrete trial is when you're sitting at the table, you would present a skill or cue the child to give you a response, and then they would give you a response, you would reinforce it. It's a lot of one-on-one at the table, kind of going back and forth, where you're targeting a specific skill, like, for example, naming letters. And so you'd present them with a stimulus, a letter, and then they would give you a response. You might prompt them. That's a discrete trial, something that's very structured, versus like a naturalistic approach where you might be on the floor looking at a book together, and then a natural opportunity where the child is touching the A, oh, that's an A, or you're in the community and you see a stop sign and you point to the S on the stop sign, or the word stop is more of a naturalistic teaching opportunity. Does that make sense? Are there
if there are follow-up questions, will you please feel free to reach out? We are always happy to, via email, continue to answer your questions as well. So thank you so much. We are over time, but I really appreciate all of the information today. A couple closing remarks. So on our new learning platform, you will find a link to today's PowerPoint and the case recommendations. Usually it will take a few days for those case recommendations to be finalized, but you can access those on the learning platform. And then also to claim your CMEs, CEs, please remember you have to claim them by 8 a.m. Mountain Time the day before our next session. So you've got roughly 2 weeks to get that processed. And if you have questions, let me know. So we're going to meet again May 9th from 12:30 to 1:45 Mountain Time. The topic is exploring differential diagnosis in autism, part 1. So this is a part 1 of 2. Part 2 will be on the 23rd. And this will be presented by Amy Francis. So we hope to see you on May 9th. Thank you so much. And again, reach out with any questions you have.